Well, good morning, everyone. I have the pleasure of introducing our guests here today. I'm Crystal Green with Elevance Health. I'm also with the WEDI board, and I have the pleasure of introducing Derrick Higgins, VP Science, Data Science and AI from HCSC, Healthcare Service Corporation, and Sid Raina, which is the HCM Technology Delivery Leader at HCSC. And this is going to be, it's a little different, the title, but it's really talking about AI and clinical review, so enabling focused clinical review with AI and intelligent system design. So we will turn this over to them, and then we will open it up for questions when they finish their presentation.
Thank you.
Thank you.
Thanks, Crystal. So I never really know, based on the audience, how much we need to say by way of introduction to the company. So Healthcare Service Corporation, pretty generic name, also known as Blue Cross Blue Shield of Illinois, Montana, Oklahoma, New Mexico, and Texas. We are currently, I think, the fourth largest health insurer in the country. We insure about 19 million members at present, I think. We are a not-for-profit health insurer. So happy to tell you a little bit about the work that we are currently doing in the clinical review space. So before we dive into that work specifically, just wanted to spend a little bit of time introducing myself and my team and our work to you, and Sid will do the same. So I usually start by telling audiences I'm a pretty technical person, which maybe people don't expect in sort of a leadership role. I feel like I have to clarify in front of this audience because it's a group of technical people, very different technical people from myself. So I've been working in AI, machine learning for a long time. So my background is in natural language processing specifically, so a lot of algorithms, data structures, linear algebra, and statistics, that kind of stuff. My team at HCSC is a group of data scientists, machine learning engineers, and product managers who build solutions based on AI to make our processes more intelligent, more efficient, to serve our members better, and also work with external parties to integrate AI solutions where appropriate. So this work affects our business in lots and lots of ways. Of course, processing claims accurately and on time is one of the main things we're expected to do as a healthcare payer. So we do have AI models that we use in that space. Just an example, it relates to penalty mitigation. So we have performance guarantee penalties that we might be subject to based on expectations that our clients have. We have specific states with prompt pay requirements. And so if our models identify that claims are on track for some sort of a penalty, then we can do a number of different things. We can either alert operators in real time that there's an issue they should attend to, or we can route claims to a specific qualified pool of operators to make sure they get the right attention in a timely manner. A lot of what we do is in the clinical operations space. Of course, today we're going to be talking about the prior authorization, clinical review stuff specifically, but other models in the clinical space as well relating to care management, so anything relating to chronic disease progression or SDOH needs or potential readmission risk once folks have been discharged from an inpatient setting. We have models that identify and estimate the relative risk of our members to help them get into appropriate care management programs. Member experience space as well. We have models to provide information to members in a timely way. We have models related to provider engagement. Some of those same models that we use for clinical risk can be used not just to help get members into appropriate care management programs, but also to help providers get insight into the needs of their patients, our members, so they can take the right action in VBC, value-based care arrangements. We have a lot of work. Again, I said my background is in natural language processing, so a big focus for us is working with electronic health records in different formats, either FHIR records or in many cases, as you'll see, we get records as images or PDFs that we have to extract information from. So extracting the information that we need for prior authorization, clinical review, extracting the information we might need for risk adjustment, extracting information that we might need for HEDIS applications, for instance. A lot of the same technology under the hood that helps us do information extraction that leads into multiple use cases. And then, of course, security, making sure that we safeguard our members' data and that we use AI appropriately to flag potential intrusion attempts or risks to information security. I should also say that we have a governance policy and procedure that encompasses all of the work that we do and all of the work that related to AI that vendors support us with. So we have requirements that prohibit us from using AI in a way that would provide barriers to care. So we wouldn't deny prior authorization requests or deny payment of claims based on AI. And we review all models before they go into production to make sure that they have been evaluated for fairness, to make sure that they're transparent, and folks who need to understand the rationale for AI recommendations have insight into those into the rationale, and to make sure that we have accountability. So we don't have any models in production that kind of nobody owns and are not maintained over time because of that. So that's kind of my role at the organization. With that, I'll pass it on to Sid.
Great. Thanks, Derrick. So I have been at HCSC almost 7 years, and I started in data analytics, but recently, last 3-4 months, I've focused more on the healthcare management side of things, and specifically care management, utilization management, and disease management. There's a whole slew of work at HCSC on upgrading some of these systems. So we'll touch on some topics today, but more than happy to talk to any of you afterwards if you want more details. Personally, just like Derrick, I'm also a little bit more technical. I have a PhD, just like Derrick. Mine is more on management science and operations research, but very, very passionate about anything clinical and anything data. So that's a match made in heaven. So you'll hear a little bit of that today. Started in academics, went into consulting, worked for Mercer more than 10 years, and have been with HCSC, as I said, last 7 years. Allowed to do things like these where we talk about topics of interest with fair-minded, similar topics with other people, especially in Midwest. So I'm part of the Evanta Midwest CDO Governance Council. I'm a co-chair, but just wanted you to have a sense of who I am, what I do. My team itself is around 60, 65 people doing care management, utilization management, IT work, platform work, based out of Illinois, Texas, Oklahoma, and such. But glad to be here.
Okay, so to get right to it, prior authorization. So as I mentioned, my role within the organization is trying to use AI to make our processes more efficient, intelligent, and serve our members better. So prior authorization is a natural area of focus for us because we know in terms of efficiency and member experience and provider experience, well, providers don't like it because it's an administrative burden for them. Members' experiences with it are often negative because it represents to them a delay in how quickly they can schedule procedures when they get access to care. And then even from a payer perspective, often the way that we implement things is really, really suboptimal. As we do a lot of review, we spend a lot of time looking at medical records, sending things back and forth, interacting with providers in inefficient ways through inefficient channels, and often, more often than not, where we end up is we approve things anyway, approve the vast majority of clinical requests that we get anyway. So we want to think about how we can get to that end state, how we can get to the determination faster so we can reduce the abrasion, reduce the negative experience for members and providers. And of course, this need hasn't gone unnoticed. There's a lot of regulatory attention to this space. There's a lot of legislative attention. And so this slide here shows a draft CMS regulation around prior authorization, which would set out more stringent expectations for lower turnaround times, for instance. So we have to think about how we're going to meet these expectations, and AI is one tool that allows us to do that.
Yeah, to add to what Derrick was mentioning, it's not just a CMS thing and a federally regulated things. A lot of states are jumping onto the same bandwagon. You might have heard about Texas gold carding initiative, and other states are starting a lot of that too. So reducing the administrative burden, making prior authorization more meaningful is pretty much on everybody's mind. So we'll see more and more of that going forward. So what we are sharing today is pertinent to the rules and regulations right now and things in the pipeline. So very important.
I think I saw somewhere between 30 and 40 states either have regulations related to prior authorization or are considering passing them. And given the 5 states that I mentioned, we're very familiar with House Bill 3459 in Texas and House Bill 711 in Illinois. So depending on where you're working, you may know some other acronyms and numbers. So how do we do this? And I feel like to really talk about it, we first need to kind of level set about the clinical intake landscape in American healthcare. So this is a graph that comes from the Council on Affordable Quality Healthcare, I think. It was a non-for-profit that comes out with an annual data report related to American healthcare. And it shows the volume of clinical review requests, prior authorization requests, by channel for the last 3 years. And so the black line there represents electronic requests. The green line at the top represents partially electronic requests. And the purple line in the middle is manual requests. So, we just, the main takeaway here, I think, for this room, hopefully, and I'm sure you're all aware of this, like that black line is the smallest number. And it's been fairly constant as a proportion of the overall review volume over the last 3 years. So most requests currently do not come in through digital channels only. We have a lot of requests that come in through digital portals, but we also have a lot of requests that come in by phone, by fax, by email. And so they do not have FHIR standard formatted healthcare records that come with them. If we're lucky, they come in with image-based electronic health records initially. Often they don't have any kind of documentation attached to them initially. So we have to really recognize where we are today in terms of the overall channels and the data that's available to us on first receipt of a request, as in the world that we live in.
I think there's one more years.
Okay. Okay. So. To jump to solutioning then, again, we've kind of talked about the desire of making clinical reviews more efficient, the opportunity of doing that through AI, and we feel like there are 3 main levers that we can pull in order to make this overall process more efficient. The first one is engineering our systems so that we collect the right information up front to the extent possible so that we can actually align that with our medical policies and understand whether an immediate approval is possible or not. So again, that sort of assumes we're getting things through digital channels, but in many cases, the digital channels that we have are not aligned with our medical policies, and so there's no way of avoiding this back and forth with the provider where we have to go get medical records and then review, which has then, of course, the knock-on effect that providers don't have an incentive to use digital channels because it's going to require some other interaction anyway. So improving our digital channels so that we're pushing out the right questions to providers to reduce the number of interactions that are necessary. The second opportunity is figuring out how to use AI to identify the easy stuff, figure out where we have the right information, either through that intake process or through stuff that we already know about our members from prior interactions to make an automatic approval up front. So just, again, being more intelligent about how we bring data into the problem. And then the last thing is, in those cases where we do need to do a clinical review, we do need to have the SMEs on our side do a review of the documentation, making their jobs easier, making the information that they need to find in those medical records much more easily available so that they don't have to find spend quite as much time sorting through those medical records.
Great. Thanks, Derrick. So pretty much the rest of the time we'll be digging deeper into those 3 areas Derrick talked about, starting with number 1. This is a portal we built. It's in production right now, which makes it a lot easier for providers to come in and go through a guided intake process so that we exactly know what they're looking for, what they're missing, and they have the capability to upload that information. So the submission process becomes much more streamlined. We can have all the policies coded into the system. We can do audits on random. It's an API-based architecture, bi-directional, works beautifully. I'll give you a demo of the UI also, and I will speak to the architecture. So you will have to, I will verbalize the architecture, you will have to visualize it, because our legal team decided not to put it in the deck. So somehow they don't want to share the architecture slide. So I'll paint a picture. Having said that, as you can see, this basically is a tool to make life easier for providers and for insurance companies too, because they get to have that guided intake, which allows us to authorize things on the fly. For example, a behavioral health authorization through this tool is 97, 98%, so that's pretty good. Only a small fraction has to be pended and attended manually. Next slide. So just talking a little bit more about the portal. So as I mentioned earlier, it's a well-designed portal. It allows you to do both prior auth and required clinical reviews. So depending on the case you have, what you're trying to put in from a provider perspective, I'll guide you specifically to the questions which are pertinent to your case. It's real time. It allows you to facilitate the provider to have a redirection of care, site of care if needed. The policy itself has been completely codified into the system, and I'll talk about that architecture a little bit more. Again, to reinforce what Derrick was saying earlier, this system, like any other AI system within HCSC, does not deny care. It'll approve it, and if it can't approve it, it'll pend it for some human beings to intervene, which are mostly clinicians, MDs who deny things if there's a reason to deny. This is, especially with the high rate of approvals, reducing a lot of the provider abrasion, provider friction, and improving basically our administrative overhead. So win-win. Before I go into demo, a little bit of what the architecture looks like. Again, you'll have to visualize it. I will verbalize it. So basically, the tool right now sits and is accessible through Validity pair spaces. I'm assuming some of you know what I'm talking about. The Validity pair spaces allows a SSO login to this platform. You'll see a demo. It's called Blue Approver. Specifically, didn't use the name in the slide. But all the data has been uploaded into the system from HCC internal data platforms, whether it's historical PA data, whether it's membership data, whether it's provider data, all of that's already loaded in. So typically when a provider goes in, logs into the system to make a PA request, the first step is, rather than me asking for all the different details, let me check whether this procedure even needs a prior auth. If it doesn't, then you don't need to proceed any further and you can provide the approval. So it's called a prior auth necessity service. That service is called an API through one of our tools. So if what you're requesting does not need a prior auth, you can proceed. That way we all save time. If it needs a prior auth and needs further details, it goes back, and that's where the guided intake happens. A lot of the information, as you will upload into what we call as a universal content repository. It's an enterprise repository which stores all this information and is available and connected to our prior auth inquiry system. So anybody through this tool or outside can go and see the status of your prior auth. So bottom line, at the end of the day, as you go through the guided intake, you upload your right information and documents, this prior auth request, if approved, gets loaded into our utilization management system. If it's pended, it's pended in front of a MD to look at. So overall, it has been a boon for a lot of our providers, and we have seen, as I said, at least for behavioral health, almost 97, 98% prior auths getting approved. So with that, could we go to the video, please?
Welcome to Blue Approver. Today we'll be walking through a specialty pharmacy submission. We'll start off by selecting the New Request button in the right-hand corner and inputting the member's 12-letter ID. From here, we'll select the patient from the family policy. As I mentioned, we'll be doing a specialty pharmacy request for today, so that's what we'll choose as our type of care. Since we are in a demo setting and we are in no rush for this submission, we'll stick with the standard request today. I'm going to input today's date, but you can go as far out as 365 days in the future or as far back as 7 days prior. For the service, we can start typing in the description or the CPT or HCPC. Diagnosis will work similar. We can start typing in the ICD-10 code or the description. If you have additional diagnosis codes, you can add them here, or you can go ahead and skip. Now we'll choose the place of treatment with the provider office is what we'll do today. As far as the ordering physician, we can search by the first and last name. We can also search by MPI number. Then we'll just select the address for the specific request. And from here, we're going to verify that Dr. Jones is going to be both our ordering and servicing provider for this specific request. If we did have a different servicing or attending provider, we would just hit no and follow the prompts accordingly to select that new provider. But we'll go ahead and continue with Dr. Jones for today. At this point, we're in the clinical review section, which will be a few yes or no questions. They should be easily understood, and you should not need a clinical background in order to answer them. From here, we'll input the patient's weight because it is going to auto-populate a treatment plan for us based on the FDA recommendations. If you do need to make any changes, you can drop your cursor at any point and make those changes as you see fit. Otherwise, you can hit next. At this point in time, if you have any additional services that you would like to add to this request, you can hit yes and follow the prompts accordingly, but we're going to go ahead and hit no and keep moving today. From here, I'm going to add my name as the contact name, and this can be you, this can be a colleague, whoever's going to be the best person for Blue Cross Blue Shield to reach out to with any questions about this specific request. If it is your first time inputting a contact, you will have to input the phone number and email yourself manually, but it will remember for the future. Fax number is optional. And then once we get to the preview here, we can see a summary of everything that we just submitted. If everything looks good, then we submit the request. Might take about 10 seconds to populate here. But as you can see, we did get the confetti and the rocket ship, which means Jerry would be able to get his treatment now if he wanted. We can print out this all this information here in a printer-friendly version by selecting print. We can also save as a PDF from there as well. And if you don't have anything further to do, then you can just hit done and return to the home page.
Great, thank you.
So that was a very quick review of a very important initiative to kind of improve our digital submission front door, to encourage people to use that front door and to capture as much as we can through digital channels, and also make sure that we use those digital submissions or process those digital submissions as efficiently as possible. I guess the next initiative then is kind of zooming back to our initial survey of channels, recognizing not everything is coming through that front door today. Like we get things through many different channels, and we want to figure out how we can use AI to deal with the data that we have for every submission, and then make the best determination as quickly as we can, as efficiently as we can, to support our members better. So we do have an AI model that is plugged into our utilization management backend system, and basically integrates as an API whenever a prior auth request would be sent to a clinician. So it doesn't matter what channel it comes into, it's going to be considered by our AI model, and that model is going to determine whether, again, acknowledging the limitations in our data, whether we have sufficient information on hand to kind of fill in the gaps to, based on prior claims that we have from a member, based on medical records we may have gotten from other interactions, to determine whether those clinical criteria are met in order to do an approval. So we may be looking for evidence that a previous treatment, another less invasive treatment has been tried in the past, maybe looking for evidence of a historical diagnosis. Some of that we can definitely get out of that structured data from prior interactions. Some of it we may be able to infer based on statistical patterns in the past. And when we can infer that with confidence, we will make a decision to auto-approve that prior authorization. Again, we're never going to deny a prior authorization based on recommendations of the AI model. The decision is just whether we're going to approve that prior auth right off the bat, or we're going to pend it for the clinical review process that would have been kicked off anyway. On average, we see that when we're able to auto-approve those prior authorization requests, members get access to care about 4 days sooner than they would have otherwise. And then finally, the last kind of lever that we're using in the prior authorization space to make things more efficient is, as I said, trying to help clinicians do their job more efficiently. Often, when we go back and forth with providers and request medical records in support of a request, they don't know what we're looking for. They don't necessarily have the ability to be selective in the documents that they export, or want to spend the time to select exactly the pages that we need. And so we may get, 50, 100 pages of medical records for a member. And when we're looking for one thing in that 100-page medical record, it's a lot of time for clinicians to just scroll through, Control F, look for what they're looking for. And depending on the OCR quality, maybe it will not be able to find it automatically. So we have AI models that are aligned to our medical policies, understand the type of terminology that relates to the policy criteria we're looking for, and can highlight those in image-based or PDF medical records, so that essentially clinicians get bookmarks. If they're looking for a COPD diagnosis, they can jump to the part of the PDF document that has it there. They're not 100%, so there may be cases where that evidence is in the medical record, but the AI is not able to find it. And in that case, the clinician will, have to fall back on their pre-existing process. But in the cases where it is there and the AI is able to find it, they can do that much more efficiently. We find on average that it reduces the clinical review time by about 1/3. So it's kind of the belt and suspenders approach, or belt and suspenders and another belt, I guess, if there are 3 things that we're doing here in the clinical review space. That's what we had to talk with you about, and I think we do have some time for questions.
Well, I'll ask the first one to get it started. So you were talking about the documentation. So I didn't see where that was in the flow. Where does that come in? Like, is that what the clinicians do? They ask for the documentation at that point before they can approve it? And what process do you use to get that information back to you? For example, there's things that are being used today, right? Attachments, CDEX, Clinical Data Exchange with HL7. Can you talk a little bit about that process and how you get that documentation to approve that prior auth?
We'll try. I mostly access the data from our source of truth where it ends up. So I can try. I don't know, Sid, if you know better than I do about that.
All the different sources of data, whether they are electronic or they are images being faxed in, they get loaded into a centralized repository. The images get loaded into what I was talking about earlier, a universal content repository, which then the AI can scan. But anything we get through digital data is also in an enterprise repository and available. But at the end of the day, all of that data which a clinician needs to evaluate will be loaded in our utilization management system for them to review.
But then, we probably need to get somebody from our clinical teams to give you more information about how that back and forth actually happens, depending on the channel it comes into, if it's through Availity, if it's through an EHR submission, if it's through fax. Fax is pretty obvious where the documentation comes from. There will be an initial opportunity to provide documentation, but then very often clinicians will request supplemental documentation, and how that gets relayed to the provider and what channel they use to submit it can vary as well. So the request will definitely go out through a secure messaging channel, and then what the opportunities are for the provider to submit it back, I'm not sure. Probably the same options: Availity, fax.
Providers where they're at. With that.
Exactly. Yeah.
Okay.
I work with these guys, not directly, but I own the 275 attachment end-to-end system. So I can answer some of the questions as we support through Availity. 275s with the CCDA, the structured, unstructured attachments, solicited and unsolicited, but we also tap into our Epic payer platforms, and we use FHIR to exchange some of the data as well. So in essence, there's a whole bunch of touch points, and it depends on where they're at in the prior auth process. They might give it to us with the prior auth request and do it through the secure messaging channels if we need more, or they might just submit it through our Availity portal, and then it goes through the system, lands in the UCR that Sid was talking about, and then their AI is pulling the data that it needs to marry it.
Thank you. Okay. We'll start working this way.
So I may have missed this when you were explaining the attachments. So the demo, it looked like they answered the questions. I didn't see the attachment piece. Whenever the request is auto-approved based off the questions, do you require supporting clinical documentation?
So, go ahead.
Sorry. It depends on the questions, right? Sometimes it's just a clarification of the question as you saw in the video. Sometimes it's additional attachments which have to be taken in, and there might be enough you can glean out of those to provide a prior auth. In some cases, it gets uploaded in the system, the PA gets pinned it, and some clinician will look at it. But now you've saved time, the back and forth between the clinician asking the provider and provider sending things back through a fax or otherwise. They have it, it'll be in their queue, they can approve it if it's the right document. So yes, what you saw, I didn't show you the portion where you can upload documents, but there is a place where you can upload additional pieces of information.
Okay.
Just one other point I'll make in connection with that question is something that we should have mentioned about all of these capabilities. They're pretty new, so they're working well, but we also want to make sure that we're monitoring them as we roll them out. And so we have an audit sample with any of these capabilities that support auto approval, where in some cases where we can auto approve, we choose not to do that so that we can reserve it, have clinical review, take a look at it as well, and then ensure that the model is working well going forward. So it may be helpful to have some of that supporting documentation for audit purposes.
Yeah, thanks for the presentation. It's great that you shared your practice with us. It sounds like you're using NLP in the text mode to try to locate the meaningful information. So maybe strategy going forward, have you ever thought about when you find it, actually have logic to be able to auto-approve based on what you see in your NLP?
Yeah, I think that's a great point. We have a lot of clinical information about our members in unstructured formats, and our goal is to integrate and normalize as much of that as possible into a single canonical repository. So that, again, we don't, when we want to build a model or do analytics, we don't have to think so much about exactly where it came from or why we know about our members. It's one unified repository encompassing lab data, claims data, information that we have from medical records as well. So
right.
that's the grand ambition.
Okay, I hope you don't mind. I'm going to kind of lead you somewhere. So if you do find it, if it's normalized and you find it, would you have logic to help auto-approve based on the evidence that's found in the document?
Absolutely, yeah. That's the goal. We want the data so that we can take action on it, take intelligent action.
And the last one, images. Have you thought about the NLP on images to be able to help find that proof point that it's actually
You mean
viable?
like radiological images? Yeah, that is something that we're thinking about. A lot of those cases are quite complex, and so those are not sort of the first tier of use cases that we would consider automating with AI.
Okay, thank you.
All right, I have one back here. So the first one is just a clarification. So the portal that you demoed is not the only channel you can enter in, right? So if I'm a provider and say I've invested in R1 or Waystar or a comprehensive end-to-end RCM solution, I can use that to basically push into your APIs to receive the request, right? So the portal is optional maybe for a provider who doesn't have that kind of complex capabilities. Is that correct? Okay, sorry.
So we directly work with Availity and then our Epic payer platform entry points, which also go through Availity. As Sid pointed out, it goes through an area of Availity that's they host for us called Payer Spaces, but we also support the 278 on Availity portal itself. Availity is our pinpoint, so we have to come through Availity right now to get to us. So as long as the vendors connect to Availity, Availity will pitch it to us.
But that was an excellent question. There is, within the Availity space, the Availity tool of choice is called AuthVisit, through which you can come and do a PA. So some of the providers decide to skip going the route I was presenting. And that's an area of opportunity to force everybody to go through this and build the smarts in there. Anything which can go through this approval tool should be routed automatically. You don't have a choice to kind of skip that. Right now, as you said, yes, they have an opportunity to skip. And some are fairly diligent about it, like behavioral health providers have been very good at it. Others, it has been a little bit of a stretch. But if we force the routing through the AuthVisit to always go through Blue Approval, we expect the usage to go dramatically higher.
Makes sense. And then the second question I was going to ask is, could you talk a little bit about the difficulty and complexity in terms of codifying all your medical policies, clinical guidelines into CQL that then can be processed as beautifully as you've shown in the demo? Can you talk a little bit about some of those complexities and how you're handling that?
Do you know more about
It's a lot of work. I mean, it's a lot of work with clinical SMEs. You got to get the docs together with the technical people to talk through how to actually operationalize the logic in our medical policies. So I don't want to trivialize that. And I think there's two parts to it. The first part is doing that codification, putting together the rules initially, and the second part is maintaining it, because those things are not static over time. And so we've sort of done the one, and we have to do the second going forward.
So one of the questions that I had with being able to auto-approve as well as pend, how often are things auto-approved? What is the percentage of auto-approval versus things going to pending? And then are you using those to update maybe your medical policies or your requirements so that those aren't even then requested because they are being auto-approved so often?
The last part first. I mean, yes, that's sort of an active area of discussion. What should our prior auth list be? What things should we be more intelligent about reviewing? What things should we not be reviewing at all? And the data informs that. And then auto approval percentage. It's very procedure dependent. So as you said, the behavioral health space is one where we have very high historical approval rates, and correspondingly, the model also has very high approval rates. For different procedures, it's going to vary, and I don't have like a top line number. I'm not sure how meaningful the overall number is.
And tying to the previous question, I think it varies. It's fairly high, and as we said, behavioral health is 97, 98%. Our issue isn't how well it performs. Our issue is getting providers to go take that route, start using the tool a little bit more. Because right now there are different ways of requesting a prior auth. They tend to bypass that and try to go the old way. So forcing them to change their behavior so that everything is forced through this route will ensure that they go this route. And we expect it will be dramatically better than what it is. Now, some might be down to 50, 60%, some might be closer to 100.
We'll take one there, and then we have an online one too. We'll come back over here.
Okay, so my question, I observed the specialty demo, and that was powerful. And I've also heard discussion about using the 278 and the 275. So my question is, are you doing prior authorization on the pharmacy side? If so, are you using NCPDP, or how are you processing pharmacy other than specialty pharmacy on the portal, which is what you demonstrated? How are you processing other pharmacy prior authorization requests?
I don't think I have the details I can share right now with my, on my person. Maybe I can connect with you later on, find the details. Thank you.
We have some online questions. I'll start with one. How are medical necessity guidelines codified in your system?
So that's the clinical codification that we referred to before. So, we have medical guidelines that are published, and those need to be turned into operational logic. So again, what information do we need to request from providers that we're not already requesting? And then how do we basically turn that into a set of if-then rules that will determine under what conditions we can auto-approve? And it's something that needs to be done in consultation with our medical directors, but then also with technical people who are in the position to write those rules. So we lock them in a room. We don't let them out until it's done.
All right, and one more. Are EMRs directly integrating with your PA APIs?
Not right now. That's the North Star. Ideally, would like to have, well, there's not one EMR EHR, as you all know. There are a multitude of those. So EMR EHR agnostic APIs using FHIR standards would be the North Star, would work on, but we haven't gotten there. So in the meantime, these are the tools we're using to make the best of it. But that'll be the ideal state, that in a provider's EMR, in their process flow itself, they ask for a prior auth, they get a response right there. And if there are any additional questions being requested, they show up on your EMR HR. Because one of the problems with what I demoed to you was a lot of that is done by the admin staff and not with the doctors. And some of these are clinical questions. Admin staff cannot really respond to that. So they have to wait for a doctor to come in and then say yay, nay, or whatever the numbers might be. If it's part of the EMR HR flow, it becomes very seamless. So definitely something we were going to go to.
But I should say as well, what we're building will translate to an EHR submission world. So we're just codifying the logic in the medical policy. Some of this stuff is going to be easily accessible from the EHR. Some of it we may need to surface as supplemental questions in the EHR, but you know, the work is no regrets work to codify the policy.
And yeah, back to that again on codifying the policies. Can I just get confirmation? Like, did you codify those into some open formats such as CQL, or is it bespoke to your system?
I don't know.
Me neither. I can say.
Okay.
I'm Mary Lee Stein. I'm over here. I'm on the codifying your additional information and thinking about the regs that are kind of looming out there. And are you codifying the additional information you need into LOINC codes? Have you, is that the codification that you're doing around additional information?
LOINC, so
that's around the attachments reg.
yeah, I'm not well equipped to engage in the language of standards that you all use.
Oh, okay.
There are going to be different components of our medical policies, from procedures to prior treatment patterns, and exactly how those are codified. I shouldn't opine on, because I'll say something wrong.
This specific system, we can go check, but we do have different systems which take CCDAs and rest of the information and pull out SNOMED and all those LOINC codes. So we do have systems do that. Do they exactly feed into this system too? I'm not 100% sure, so I'll have to check on that. But yeah, we have a separate set of systems which do exactly that. We call them clinical data accelerators. They do this taking all the data in and uplifting, and it has its own elements of understanding what's missing, what the gaps are. So a whole slew of CCDA documents from all the different areas, including our EMR, EHR portals.
All right. Well, great. We're at time now. Great questions, and we want to thank our speakers here for coming and sharing that information with us today.
Excellent.
Thank you very much.